Welcome everyone. I'm just going to wait one more minute to give everyone a chance to join us, and then we'll get started. Okay, it's 6 o'clock, so I'm going to go ahead and get started, and if there's some stragglers, they will fill in as we get started here. So I just wanted to thank you all for joining me today for this online lecture. I'm Eve Hoffman. I also wanted to thank the Gildenhorn Institute of Bone and Joint Health for supporting this lecture series. So the format tonight will be a short talk on modern advances in the management of low back pain. And then we'll have plenty of time at the end for questions from the audience. We will be using the question and answer function rather than the chat function on Zoom. So if you do have any questions, please submit it through the question and answer tab, and I will go through those questions towards the end of the talk and answer as many as I can. So just a quick introduction to who I am. I grew up here in DC. I went to Georgetown Day School, which was originally located just down the street from Sibley Hospital. And this is a picture of me with my high school cross-country team. After I graduated from high school, I went to Brown University and stayed at Brown for medical school. And then after graduating from medical school, I did my orthopedic surgery residency at the University of Maryland and Shock Trauma Center in Baltimore. This is a picture of my graduating residency class on the helipad of shock trauma on our last day of residency. And then following residency, I did an additional year of training in spine surgery at the Rothman Institute at Thomas Jefferson Hospital in Philadelphia. So a couple of pictures of me in the operating room and with my co-fellows. And then finally, I joined a great group of surgeons at Summit Orthopedics, where I see patients at 2 office locations. One is in Chevy Chase and one is on New Mexico Avenue near American University. And I do all of my surgery at Sibley Hospital. So just a brief overview of this talk. Because we have limited time here, we're going to be focusing primarily on back pain. Although back pain often coexists with leg pain, or what many people refer to as sciatica type pain. We won't get into the details of sciatica in this talk, but it is important to recognize that those two things do frequently overlap. So just a very brief anatomy lesson to start us off. So the spine is a column of bones which provides stability to the body. It helps to protect the spinal nerves and the spinal cord and allows for motion of the body. We're going to be focusing on the low back today, also called the lumbar spine, which is made up of 5 bones which provide support. And then in between the bones are discs, which act as shock absorbers and allow for motion between each level. And then at each level, there's a corresponding nerve, as well as joints and ligaments, which help support the bones. So who gets back pain? It's important to remember that almost everyone, 80% of the population, will have an episode of back pain at some point in their lives. And the majority will actually have recurrent episodes. However, it is very rare to develop chronic pain or pain that is debilitating. The overwhelming majority of cases resolve within 1 month, and only 5% of cases will lead to prolonged pain severe enough to cause disability. I'll give everyone a few seconds to appreciate the one joke that I could fit into this short lecture here, and then we will discuss the different causes of back pain. So the most common cause of back pain in every age group is a sprain or a strain, which is due to abnormal stretching or tearing of the ligaments or muscles of the back. Luckily, this generally resolves with very little intervention needed within usually about 10 to 14 days. The next most common cause of back pain is injury to the disc. And as this diagram shows, the disc itself, which is the material in between the two bones, is made up of an outer layer called the annulus, and that's a really thick outer layer. You can get a tearing in the annulus itself, which is depicted here, and that can cause back pain. And then sometimes that tear can cause some of the inner material called the nucleus to actually escape out of the tear and cause what's known as a disc herniation. And that disc herniation can result in both back and leg pain due to irritation of the surrounding nerves. So I've also included some imaging of MRIs to help us sort of show the difference between that annular tear and the disc herniation. So in this view on the left-hand side, we're looking at the spine from the side. These lighter gray blocks are the bones, and then the discs are in between each of the bones. And this very bottom disc that I'm showing right here has a bright white spot here, and that's actually corresponding to an annular tear or a tearing to the outer covering to that disc space. This image here on the right shows at this level here that some of the inner material has actually escaped out, and this is a disc herniation, which is actually occupying the majority of the spinal canal here. Another common cause of back pain, especially in the population of patients over 50, is arthritis. As we age, our disc spaces get dried out or dehydrated, and then they become more prone to injury or collapse, which we refer to as degeneration. And our bodies actually attempt to adapt to the degenerative disc by placing more of our body weight through the bones of the back. So this abnormal mechanism could lead to wearing away of the cartilage and bone spurring. And we can try and distinguish between pain primarily from the discs, which is usually made worse when people bend forward, whereas pain from the joints is made worse with arching your back backwards, although the two of them commonly coexist as well. Less common causes of back pain include fractures or breaks, infections, tumors, or spinal deformities such as scoliosis or curvature to the spine. So how do we diagnose back pain? The initial and primary diagnostic tool that I use is a physical exam, which includes assessment of gait, sensation, strength, and reflexes in the lower extremity, and then palpation or feeling different parts of the low back, as well as range of motion testing. These are all helpful to delineate different sources for low back pain. In addition to physical exam, I oftentimes will order imaging of the low back. So an X-ray of the low back I order for patients who are reporting symptoms for longer than 6 weeks, but I will sometimes order them earlier if this is a recurrent episode of back pain or if I'm concerned for something more serious like a tumor or an infection. And I've included here what normal lumbar spine X-rays look like. We can see on an X-ray the bones and the overall alignment of the spine, and we can see the space where the discs are, but I cannot see the discs themselves like I could on an MRI. And so when do I order an MRI? I usually reserve it for the small proportion of patients who don't get better after an initial round of conservative management. But again, similar to X-rays, I would order it earlier if I was concerned for a neurologic deficit like weakness in the legs or other types of things that I may not see on an X-ray, like a stress fracture, infection, or tumor. And again, the MRI shows me the disc spaces themselves. It also shows me the spinal canal and the nerve roots, which I'm not able to see on an X-ray. So now let's get into different treatment options for back pain. So the most important thing to remember is that most episodes of back pain will improve over time, regardless of the treatment option, and will not progress to chronic pain. That being said, we'll spend the rest of the lecture reviewing the most effective treatments that are available for back pain. So many causes of back pain cause inflammation within the body, such as muscle strain, the disc injuries, and arthritis that we just discussed. So the primary medical treatment for back pain includes non-steroidal anti-inflammatory medications. These are the common things that you've heard of, such as ibuprofen, naproxen, Celebrex, or meloxicam. There's no evidence to suggest that one particular anti-inflammatory works any better than any of the others. I oftentimes prescribe meloxicam. That's the one I like because you only have to take it once a day, so you don't have to remember throughout the day to continue to take medicines. A steroidal anti-inflammatory is usually reserved for patients who have severe nerve or sciatica type pain rather than low back pain. And then muscle relaxers can be helpful for acute muscle spasms, but there is no good data in the orthopedic literature to support the effectiveness of these medications for low back pain. So I usually only prescribe them for very short courses in patients who are really complaining of muscle spasming. And I'll almost always do it along with an anti-inflammatory medicine at the same time. And then there's other types of medicines that can be helpful. So gabapentin and Lyrica are two medicines that have been proven effective for nerve type pain, but not for low back pain. However, there is a strong link between depression and chronic low back pain. So antidepressant medications can work to relieve pain in patients who do have depressive symptoms at the same time. And then finally, I do not prescribe opioids or narcotics for back pain, and this should really be avoided at all costs. So some of my patients ask about cannabis for treatment of back pain, and the best studies of this have actually been performed in Canada on a synthetic cannabinoid that is similar to the active ingredient in marijuana. So the Canadian equivalent of the FDA found that there was actually insufficient evidence to support the benefit of this medication for back pain, and that there were obviously some risks and side effects involved. And so they are not recommending this for back pain. And in general, I don't prescribe medical marijuana to my patients, although again, there is an antidepressant and anti-anxiety effect to some of these medications, which do have strong links to chronic back pain. So I think there are certain patients who get good relief of back pain with medical marijuana. In addition to anti-inflammatory medications, physical therapy really is the primary treatment for low back pain. There are a few specific types of therapy. However, we know that core strengthening programs to strengthen the back and the abdominal muscles is really the most effective treatment. But I'll go over in the next couple slides a few of the specific different types of exercises. So Williams flexion exercises are one type of therapy which was popularized in the 1930s with the goal of enhancing lumbar flexion, and this avoids lumbar extension, but again, focuses on strengthening the core muscles. On the other hand, the McKenzie exercises, which were originally described for disc herniations, begins with lumbar extension exercises and then progresses to flexion. So both the McKenzie and the Williams programs have been shown to reduce low back pain, and there has not been a proven difference between the two different types of exercises. There are a host of other modalities that physical therapists may incorporate into a treatment program, and these include a TENS unit, heat or ice therapy, massage, traction, bracing, and ultrasound. There's unfortunately in the literature no proven benefit for any of these, but they all have very low side effects. So when I see patients, I often send them, when they present with acute back pain, I send them to therapy. And in the early stages, the therapists are often doing heat, massage, ultrasound, or using a TENS. And that gets them through the really severe early stages until they're able to start participating in more core strengthening exercises. As I previously mentioned, we know that many patients with chronic low back pain have associated depression. So a mindfulness-based stress reduction is a technique which combines both meditation and body awareness and has proven benefits. It's not easy to find a practitioner that participates in this program, but it can be quite helpful in the appropriate patient. And then lifestyle changes are also incredibly important, especially right now as everyone's working from home. We really need to be conscious of the role that ergonomics as well as a sedentary lifestyle play in the development of low back pain. We know that obesity, as well as repeatedly lifting greater than 25 pounds, especially for work, has the highest risk for development of chronic low back pain. So these are some things we can think about and try and adjust to decrease our risk of developing symptoms. Next, I'm going to mention a couple alternative therapies for low back pain. So acupuncture is the first one. The effectiveness of acupuncture for low back pain has been studied. We know there's some moderate evidence for the effectiveness for chronic low back pain, only limited evidence in the acute low back pain patient. There is, however, a very strong placebo effect. So there were some studies that looked at sham acupuncture where needles were inserted at random points in the body rather than following the specific guidelines of traditional medicine. And they showed that sham acupuncture is generally as effective as traditional acupuncture for decreasing back pain. And then chiropractic manipulation of the spine also has some limited evidence for its effectiveness. However, there's no evidence that it's any better than other treatment methods that I just discussed, such as physical therapy, medication, and exercise. And then just as an aside, I caution strongly against any chiropractic manipulation of the neck because it does have the potential for worsening of symptoms and neurologic complications. So I'm usually not sending my patients for acupuncture or chiropractor unless they've already tried the medical management that we've discussed and the physical therapy. Next, we're going to review some different options for interventional pain therapies. So an epidural injection is the primary one that many people have heard about. This is an injection of a small amount of steroid on top of the nerves of the low back. This is generally much more helpful for leg pain rather than back pain, as the goal of this injection is to decrease nerve inflammation. So there's not really any evidence to support epidural injection as treatment for back pain alone without any associated leg or sciatica type pain. For patients who do have primarily nerve pain, there is some evidence to suggest that the epidural injections may offer a short-term benefit compared to injecting a placebo. So a different type of injection which is more appropriate for patients with primarily back pain is called a facet injection. This is an injection of steroid which is targeted at the joints of the low back and is useful in patients with arthritis. And I find it to be useful for diagnostic purposes. Unfortunately, the pain relief only lasts up to 3 months. But if you do get good relief from this, there's a follow-up procedure called a radiofrequency ablation, which can offer more lasting relief. And then there's some more recent interest in treating low back pain with treatments which fall under the category of regenerative medicine or orthobiologics. These treatments use biological substances to help musculoskeletal injuries heal quicker using substances that are naturally found in the body. So the most common examples of this are platelet-rich plasma and mesenchymal signaling cells or stem cells. So what is platelet-rich plasma? So platelets are one type of cell found in our bloodstream, which has the potential to help with healing. Platelet-rich plasma is obtained by taking a sample of a patient's blood and then using a centrifuge to spin it down and separate the components. And then the plasma component, once it's spun down, contains a concentrated solution of platelets, and this solution can be injected into various locations of the low back. And then stem cells are cells which have the capacity to differentiate into regenerative tissue, allowing for local tissue repair, as well as decreased inflammation. These cells are usually taken from bone marrow or from fat cells and can be injected again into various locations of the low back. Currently, there is very little evidence to support any benefit from injection of either the platelet-rich plasma or stem cells for low back pain. And because of that, unfortunately, they're not covered by insurance. There's a lot of ongoing trials right now, and I'm hopeful that at some point in the next couple of years, we'll have some more data to support the use of these different injections. And at that point, once we have some proven data, the goal would be that insurance would start to cover these. And then finally, we'll briefly discuss who needs surgery. So in general, spine surgery is more reliable for treatment of leg pain due to nerve compression and is much less reliable for the treatment of back pain. And as a result, I actually very rarely perform surgery for back pain alone. And it's usually as a last resort for very specific types of diagnoses. On the other hand, the majority of surgery I perform is for nerve compression, resulting in primarily leg pain, and these patients all do very well. But if you do end up needing a surgery for back pain, the goal of the surgery is to remove or stop any pain generator, which is usually a combination of that degenerative disc we discussed, as well as the arthritic bone and joints. So in a surgery for back pain, the goal is that we remove the disc itself, and it gets replaced with a spacer that's filled with bone. And then screws and rods are placed along the joints in the back with the goal of fusing the segment and stopping any motion across the section of the spine. And so that's what it looks like. And then this is just what an X-ray looks like, with the ultimate goal that you'll see some bone that fuses across that disc space as well as across the joints in the back of the spine. So that's what I had for our lecture today. I wanted to thank everyone. This is just a little bit of contact info for me. And then let me take a quick peek at questions. So the first question I have here is, how can I tell whether I should see an orthopedic surgeon or a neurosurgeon? And that is a really great question, which I get frequently. So the difference between an orthopedic surgeon and a neurosurgeon is, I'm trained to operate on the spine, and I can also do other types of orthopedic surgery like fixing hip fractures, et cetera. Obviously, neurosurgeons are not doing that. Neurosurgeons operate on the spine. They also operate on the brain, which I don't operate on. So they operate on the brain. I don't. I operate on lots of other bones and joints, which they don't. And then there's overlap, which is the majority of the spine, which we're talking about today. And in terms of the overwhelming majority of spine surgery, either a neurosurgeon or an orthopedic surgeon is well trained to operate on and handle any of the issues. There are a few things which I don't do, which neurosurgeons do, and the distinction is that there is a covering to the spinal canal, which is called the dura. If you've heard of people having spinal fluid leaks, that's a leakage of fluid on the inside of that covering that leaks out. And so I do not operate on anything on the inside of that spinal covering. So rarely people have tumors or other masses on the inside of that covering that I don't operate on. But again, the overwhelming majority of diagnoses within the spine, both a neurosurgeon and an orthopedic spine surgeon treat. And then the next question is, why do I avoid opioids when low doses have shown to be effective and non-addicting? So I try and do my best to not jump to opioids, because we do know that there is a small percentage of people that can become addicted. I think especially for chronic back pain, you want to avoid being on an opioid. There are many alternatives that we just went over. So I always start with the anti-inflammatories, and then if that's not working, we have many additional options for treatment. So I do my best to avoid opioids. Obviously, I do prescribe opioids for patients who have just undergone surgery when you're really treating something acute that you anticipate to get better quickly. And then the next question I have is, what can be done for a mild retroathesis of the spine? So that's a word that we hadn't discussed in this talk, but is a medical term for when some of the bones sort of shift abnormally in the spine. And that is actually something that I would tell you doesn't really need much treatment unless you're having real symptoms. A retroathesis is a shifting of the bones that is actually inherently stable and means that the bone's not going to be shifting back and forth in any abnormal way during day-to-day activities. So that may be something that someone read on an MRI report and thought sounded scary, but is actually should be reassuring. It's essentially a mild arthritis of the spine. And then let's see, lots of questions here. So I have a question that says, what is spinal stenosis? That's a really great question. So again, I was trying to focus on primarily low back pain in this talk, but a primary cause for sciatica or nerve type pain is that the area for the nerves in the spinal canal gets smaller, and that's what spinal stenosis is, where the area that's available for your nerves in your low back is smaller than it used to be. And again, that is a process that occurs, it usually occurs over time as a result of that degenerated disc that we talked about and the arthritis in the joints that we discussed. The combination of those two things creates or sort of takes up some of the space that previously was occupied by those nerves. And over time, that can lead to pain that goes down the legs. And then the next question I see here is, can facet injections be performed by a non-surgeon? So yes, facet injections are usually actually performed not by a surgeon, but by a pain management doctor. And so I actually don't perform any of those injections that we talked about, but I do have a pain management doctor in my group who I will send my patients for injections. Just sort of in terms of the logistics, that when you see a surgeon, they're usually seeing patients in the office a couple days a week and then doing sort of larger surgeries the other days of the week, whereas a pain management doctor does a lot of those injections. So that's usually how that works. And then I'm seeing, does a herniated disc ever heal? So that's a great question as well. Your body does have the ability to sort of resorb that disc herniation over time. And so the goal, you know, most people that have a disc herniation don't end up needing a surgery. So the goal of treating that disc herniation is trying to decrease the inflammation in the nerves. And over time, that should help with the leg pain. And then you can let your body have a chance to resorb that disc fragment over time. In some patients, that doesn't happen, or the pain is so severe that they end up needing a small surgery to remove that disc herniation. All right, let's see, just going through a couple other questions here. So someone asked, what is the recovery period for fusion to get back to full use? So that's a good question. So again, the goal of the fusion is that your own body is actually going to create bone across that disc space and across the joints in the back. And that takes anywhere from 6 to 12 weeks for your body to fuse that. And so, you know, by the 6-week point, you're really feeling pretty good, but I usually would wait until the 12-week point to let you get back to really any high impact exercise or activity. But there's no restrictions after that 12-week point. I let patients go back to skiing or, you know, other high impact activities, and that is fine as long as we've shown that you have fully fused across that disc space in the joint. And so someone asked, how many times can you repeat an epidural injection? So I don't have a hard rule on how many times, because I think if you get some relief that is beneficial and you're satisfied with the amount of relief that you get, that's something that's an option for you and you can continue to do that. What I have found is that as patients continue to get injections, they may find that they're not getting quite the amount of relief or quite the duration of relief from each successive injection. And so oftentimes there comes a point where my patients will say, you know, my third injection only gave me about 50% relief and it really only lasted a couple weeks. And so now I think I'm ready to talk to you about the next step, which may be a surgery. But again, I don't have a hard rule on that because I think for the most part, they are pretty low risk procedures. And obviously it's, the alternative is a surgery, and that's obviously a big decision to make. And someone asked just a follow-up question on the spinal stenosis, which is how do you diagnose and treat it? So I should have answered that previously. Thank you for the follow-up question. So spinal stenosis is diagnosed, again, similar to what we talked about. Always start with a physical exam. Patients with spinal stenosis, again, usually complain about pain that radiates down their legs like sciatica, or oftentimes they complain of weakness in the legs when they walk that gets better when they stop walking. And then, similarly, I would get x-rays and an MRI. The MRI is the thing that's going to show me that there really is narrowing of the spinal canal or around the nerve roots. And then the treatment is similar. I always start, if you've only had symptoms for a few weeks, I would always start with an anti-inflammatory and physical therapy. And then, unlike for low back pain, the epidurals can be helpful for spinal stenosis, because the goal is to decrease the inflammation in those nerve roots. And then again, over time, as the disease progresses, the patients may find that the epidurals are not quite as effective. And spinal stenosis is a diagnosis that is very amenable to a surgery. And the surgery itself would be to open up the space where the nerves are being pinched to provide additional space for those nerves and to get it back to sort of how it was or before the spinal stenosis developed. There are some situations in which you do not need to perform a fusion at the same time. And then there's other situations in which spinal stenosis requires both that opening up of the space as well as a fusion procedure. And that sort of depends a little bit on how the spine looks on x-rays, and making sort of additional diagnoses associated with the spinal stenosis. Okay, I have a question about posture, and I think that's a really important question here. People come in and say, how do I make sure I have a better posture? How do I work on my posture? And that's definitely something that I think the physical therapists are really good at. The ergonomics, I think the basics of ergonomics, especially for us working from home a lot more now, is to make sure that we have our workstations set up for us so that we can sit in an upright position. We want to make sure that the screens that we're looking at all day long are at eye height, so that you're not bent down or extending your neck in any position, and then that everything that you're using is sort of right at, you really want everything in your body to be at a nice 90-degree angle. So making sure your feet reach the floor and that your thighs are parallel to the floor when you're seated. And same thing with your arms and your elbows at a 90-degree angle when you're working. And then again, a lot of the postural stuff really has to do with working on strengthening the muscles of the back as well as your core. I have another question about the difference between a herniated disc, a slipped disc, and a bulging disc. So this is a little bit of a technicality related to how the radiologists are reading the MRI reports. But a herniated disc, again, is when some of that squishy material on the inside of the disc escapes out that annular tear and presses up against the nerves. A bulging disc really is that it hasn't escaped out that tear, but it's a little bit collapsed and is sort of rounded back towards the nerves, but not quite pressing up against the nerves. And then I don't use the term slipped disc because I think it's confusing. That often can refer in different, if people are reading their MRI reports or reading other things, can refer to an abnormal position of the bones, which is called spondylolisthesis, which someone asked a question about earlier. But when you get x-rays, you can sometimes see over time the bones sort of slip forward or backwards in relation to each other. And so sometimes that's referred to as a slipped disc as well. All right, I have a question about running, degrading the lower spine. So I think, when I see patients who have back pain, I do try and have my patients pull back from the really high impact exercises for the time being, but that's not to say that they'll never be able to get back to those exercises. So the high impact things that I try and have my patients avoid while they're in the midst of an acute episode of pain would be running, jumping, or any heavy weightlifting where they're bending at the waist or not supporting the low back. But again, I think the goal of all of the treatments we discussed is that over time, we're trying to get everyone back to the activities that they want to be able to do. So, I never like to tell a runner they can't run anymore as a runner myself, but we do know that it does put more impact on the spine. So if you have spine issues already, it may mean just taking a break or just lessening the number of miles you're running until you start to feel better. All right, let's see. I have a question about inversion tables. So this is a device that the physical therapists often have, or you can buy yourself, which essentially you can go onto an inversion table and you go upside down. And so again, we discussed the discs, which act as our shock absorbers. In everyone, they can collapse over time. So an inversion table sort of temporarily elongating those discs and can offer you really good relief. I think that certain patients really love them. They are not structurally changing anything in the spine, but again, I think if people find that they help symptomatically, they can be really effective for a period of time. So I think what I usually do is have my patients try an inversion table with the physical therapist, and then if they really like them, think about getting one for home. And yes, the recording of this will be available. Someone asked that. We are recording and you can watch this and look over the slides at some point. I'm going to try and avoid answering any of the very specific questions, but I'm always happy to, obviously see you in my office and talk about any specific surgical questions or questions about the low back or neck. So I have a question about how do I know if my hip, buttock, and leg pain is sciatica? So that's a great question and something that is sometimes confusing to figure out. And that's part of sort of my job in terms of a physical exam. I would say I have some partners who do hip and knee replacements primarily, and we're constantly referring patients back and forth because someone shows up in my office and thinks they have something going on with their spine, but after doing some x-rays or doing a physical exam, we find that actually it looks like it's coming from hip arthritis. And then same thing, I have those partners that are seeing patients for hip or knee arthritis and think, I think this is coming from your spine. And so, it's really a combination of the physical exam and then looking at imaging to help us sort that out. In some situations, it can be quite tricky. And, some of my partners see patients on the same day as me, and sometimes we sort of pop back and forth and see each other's patients. And obviously, we're always talking to each other about the tricky cases and trying to sort that out. And the other important thing to realize is that oftentimes it can be both things. Oftentimes patients come in and they say, I'm planning to get my hip replaced. Should I have something done with my low back first? Should I wait until afterwards? And that's also really just a case-by-case basis to sort of try and figure out the details of what makes sense. Great questions. So I have a question here that says, do discs ever fuse on their own? Very rarely. You can get what's called an autofusion or fusion of bone across the disc space. Usually that's a result of some sort of trauma, like you had an injury to that disc or the bone at some point in the past. Or there are some types of genetic disorders that cause you to fuse across those levels, or very advanced arthritis. Sometimes you can see the bone spurs that actually sort of arch across the levels and fuse the levels of the spine. All right. Let me just see if I can find a couple other questions here, and then we're going to wrap up shortly. So someone asked a question about anti-inflammatory medication and heart disease. And I think this is another area which I, often try and talk to patients' primary care physicians and really figure out a balance. There are certain anti-inflammatories which the primary care doctors really don't want you on if you have heart disease or on a blood thinner. And there are a few that they will allow for a short period of time. So for these patients, I will try and either talk personally to their primary care physicians or have them touch base with their primary care physician to figure out which ones make sense and for how long it makes sense. Again, ideally, I'm not putting patients on an anti-inflammatory for a very long time. We're trying it as an initial treatment, and for the majority of cases that does work, and then we're able to come off of those medications as the symptoms decrease over time. All right, I think I answered the majority of these questions. I'm really sorry if I did not get to your question, but I really appreciate everyone participating today. And again, I'm happy to answer any. I know I had a couple questions here that were sort of more specific questions about personal medical history, and I would be happy to answer those questions in more detail and look at imaging and do an exam. If you're able to do that. I will, just as a last sort of aside, I am also doing telemedicine appointments, and that's something that can be scheduled with my office, fairly flexible schedule for that, if someone wanted to ask a question or get a little bit more into specific details. So thank you so much, everyone. I think we're gonna end it there, and I really appreciate everyone's participation and hope you have a great rest of your evening.